Okay.
Good morning, everyone. I'm going to present on behalf of Medicine Unit 3. 39 years old Mr. N, welder by occupation. He was incidentally diagnosed during voluntary blood donation to have HIV since 2018. His baseline CD4 status not available. He was prescribed TLE since 2018, but he is non-compliant to medication and is completely off medication for past 2 months. There is no past history suggestive of opportunistic infections. He now presented with the complaints of breathlessness on exertion for 3 months, cough for 3 months, fever for 1 month, loose stool for 1 week, and significant loss of weight and loss of appetite. So breathlessness, which is insidious in onset, progressively increased to MMRC grade 4, decreased effort associated with decreased effort tolerance and no orthopnea and no PND for the past 3 months. Cough with mucoid whitish expectoration for past 3 months. Fever for past 1 month, which is high grade, intermittent with chills and rigor. Loose stools, 2 episodes per day. Small volumes, watery with no blood, no mucus, and no abdominal pain or cramps for past 1 week. And loss of weight of around 30 kgs over the past 6 months. He is a known hypertensive and diabetes mellitus, high risk behavior present, and drug history. He was on tenofovir, lamivudine, and efavirenz, but he is non-compliant to medication. Vitals in the emergency department, respiratory rate is 36 per minute and the saturation is 82% at room air, which increased to 98% with 2 liters of O2. On general examination, he was looking thin built and poorly nourished and wasting of limbs, pallor, grade 1 clubbing and left inguinal lymphadenopathy present, and thin sparse hair with the chirion. There was a wasting of buccal pad of fat, and there is a bitemporal and supraclavicular hollowing and oral candidiasis and herpes labialis were present. On systemic examination, respiratory system, normal vesicular breath sound here, and mild bilateral infrascapular and infraaxillary crepitations here. Other system examinations normal. So case summary is 39 years old welder, known case of retroviral positivity, now come with significant weight loss and appetite with respiratory symptoms for past 3 months and GI symptoms for past 1 week. What are all the differentials?
Okay.
Thank you for the response. However, differential, we consider separately for the lungs, respiratory symptoms and GI symptoms. In respiratory symptoms, because of the chronic cough with the fever and breathlessness with the hypoxia in a seropositive patient, we initially consider as an opportunistic infection, but the patient present very acutely to ED. So we considered still bacterial pneumonia is the first cause of in our differentials. Bacterial pneumonia usually caused by Streptococcus pneumoniae, Haemophilus influenza. In seropositive patients, we also consider Staph aureus and Pseudomonas aeruginosa, followed by PCP, followed by pulmonary tuberculosis, followed by atypical mycobacterial infection like Mycobacterium avium and Mycobacterium intracellular species, and other fungal pneumonias like histoplasmosis and Aspergillus, and the idiopathic interstitial pneumonia, which is among idiopathic interstitial pneumonias, lymphoid interstitial pneumonitis and non-specific interstitial pneumonitis is observed in seropositive patients, followed by lymphoma and Kaposi sarcoma. For GI symptoms, our differential considered were first thing is bacterial, Salmonella, Shigella, or Campylobacter jejuni, and Protozoa, Cryptosporidium, followed by Isospora, followed by Mycosporidium, and virus, Cytomegalovirus, and fungal causes are histoplasmosis, coccidiomycosis, and penicillinosis, and final thing is AIDS enteropathy. So the investigation showed initial CD4 count of 24 and CD4 percentage is 10%. CBC showed anemia with a normocytic normochromic, and liver function test showed a reversal of AG and elevated alkaline phosphatase of 903 with GGT of 455, and electrolytes showed hyponatremia. And this is the initial chest X-ray at the time of presentation to ED. It showed reticulonodular opacities. The ABGs at the time of admission, PO2 is 81 and arterial gradient is 82 millimeter of mercury. But during the ward course within 6 hours, the arterial gradient progressed to 46 and hypoxia from 81 decreased to 65. There is a worsening hypoxia. And because of the patient presented with a cough, breathlessness, and a fever with a hypoxia with a normal chest, in the view of high suspicion of PCP, we have sent LDH, which was elevated, and sputum induction for PCP PCR was negative. The patient admitted in outside hospital prior come to our ED. In that, the sputum has grown Klebsiella, which is sensitive to all except cotrimoxazole. Because a sputum induction for PCP PCR was negative, so we proceeded with the further higher imaging. This is a CT thorax and abdomen, which showed multifocal patchy areas of ground glass opacities in both lungs and focal areas of consolidation in posterobasal lower lobe and pneumomediastinum and bilateral pneumothorax. And other opportunity screen was negative except for stool parasites, which came positive for Cryptosporidium. Before going to our case of final diagnosis, I want to highlight PCP infection presentation in. Like this was a study done in 2012 till 2012. There are 11 pneumomediastinum cases identified in patients with AIDS. Among these 11 cases, 9 was found to be due to PCP, and remaining 2 was found to be cytomegalovirus. This is another patient presented with pneumomediastinum who was diagnosed to have PCP. And there is another case study which is done in 2009 to look for spontaneous, like 105 HIV infected patient who developed spontaneous pneumothorax, who was not effective ART therapy. Among this, the causes of the bilateral spontaneous pneumothorax was found to be pneumocystis jirovecii pneumonia, whereas the unilateral spontaneous pneumothorax was commonly associated with the bacterial pneumonia. Among the spontaneous pneumonias, the CD4 count, those patients who have CD4 lymphocyte count of more than 200 was usually the most common cause is bacterial pneumonia. And the patient whose CD4 count is less than 200, the pneumothorax cause was usually found to be pneumocystis jirovecii pneumonia. And this is one case report where this patient is a 31-year-old male with history of Ewing sarcoma, and he was on immunomodulators, TNF-alpha inhibitor drug. But he was found to have bilateral pneumothorax and pneumomediastinum. And later he was found to be positive for PCPs. And the PCP, the PCP definitive diagnosis is identifying the organism. Either we are doing like PCP PCR or special stain like methamine silver stain, or by immunofluorescence staining using antibodies. The optimal specimens we used to identify the organism are sputum induction followed by bronchoalveolar lavage or tissue biopsy or a endotracheal aspirate. But in our patient, the PCP-PCR was negative. Sputum induction for PCP-PCR was negative. We didn't proceed to BAL tissue biopsy or ET tissue biopsy because of the financial issues. And then a presumptive diagnosis can be made of PCP pneumonia, can be made by low CD4 count, like CD4 count less than 200, elevated 1,3 beta D glucon, that is more than 80 picogram, and then clinical features of like cough, breathing difficulty with a normal chest examination, a normal respiratory system examination with hypoxia, and the radiological findings of like X-ray show reticulonodular opacities. HRCT shows ground-glass opacities. The usual treatment for PCP preferred regimen is trimethoprim and sulfamethoxazole. The duration of treatment is 21 days. We usually grade the severity as mild, moderate, and severe based on arterial gradient. The importance of grading is for the indication of steroids. If it is moderate and severe disease, then we need to supplement steroids to the patient. So in our diagnosis, based on all this evidence, a patient living with HIV in stage 4 presented with a PCP pneumonia with a rare radiological finding of pneumomediastinum and bilateral pneumothorax with the cryptosporidium infection, with the oral candidiasis, with the herpes labialis and diabetes mellitus and hypertension. So in our patient, he was started on Septron 960 mg, 2 tablet twice a day. The plan was to give for 21 days, and steroids initially he was started on 40 mg twice a day for 5 days, followed by 40 mg once a day for 5 days, and followed by 20 mg once a day for 21 days. Then he improved for Klebsiella pneumonia because he was resistant to Klebsiella resistant to clotrimazole. He was started on Piptas, and he received 7 days of treatment. He improved clinically. We tapered off the oxygen. We are planning to start him on prophylactic dose after the therapeutic dose is over. For cryptosporidium, he was started on tab-nitazoxanide 500 mg twice a day for 2 weeks, and he had elevated ALP. The infiltrative liver disease was considered. However, the imaging showed no organ involvement or adenopathy, and bone marrow is also normal. So we have planned to monitor him on OPD basis, and we also plan to restart on TLD. My learning points are: a rare clinical presentation of PCP in patients living with HIV, approach to respiratory involvement in patients living with HIV, and diagnosis of PCP and treatment of PCP. Thank you.
Thank you. Any questions?
It's a very good case. In the sense we have approached it by person. But actually, the pneumomediastinum, did you find it clinically or it was a radiological diagnosis?
Radiological diagnosis.
Can you find pneumomediastinum clinically?
Yes.
There's something called Harman's crunch. So there will be like actually somebody crumpling the paper along with the hard sounds. So this is actually a very good patient for you to go back after you at least found it on the radiology show and found it. So it is a clinical diagnosis. At least go and you should read papers. There are actually videos and audio. You hear the crunch and then more.